well, doesn't matter. When we're looking at the respiratory system, a lot of the times we want to be able to know what are, air is going in, air is going out. We know this. That's part of inspiration and expiration. Sometimes we want to know volumes, normal volumes that should be going in, normal volumes that should be going out. And I'm like, even if there's differences between some of these, there might be something wrong. Now, there are 4 basic volumes to know. The first one's called tidal volume, which it's the smallest range, and it rises and falls like little tiny tides, hence the name. Now, tidal volume, I would never ask you a number. I wouldn't be like, oh, what is the average tidal volume? Just so I'm like, if you see a diagram that looks like this, and I'd be like, labeled, A, B, C, D, because look, there's 4. Which one's tidal volume that you could recognize that? Now, tidal volume, this 500 milliliters, this is the air that when you guys are just sitting there, not trying to breathe extra or push out any air, this is the volume of air that's going into your lungs and out of your lungs. Normal, restful breath. That's your tidal volume. So you are breathing in and breathing out, just sitting there right now, about 500 milliliters of air. So yes, it's rising and falling like the tides, just as you are breathing in and breathing out. Now, your inspiratory reserve volume, this is the volume, minus what you normally would breathe in, if you forcefully try to breathe in the biggest possible volume. I'm like, so right before you're going to go diving and you want to take a really big breath of air, you can suck in like another 3,000 milliliters of air, about 3 liters. So this is, your normal breath, and then be like, the biggest possible breath. That's your inspiratory reserve volume. Even in volume, air is going in. So, normal breathing, I just breathed in, then I'm like, an extra 3 liters of air. Now, the opposite, your normal breathing, you just normally breathed out. What do you think your expiratory reserve volume is? You try to force all the air out of your lungs that you possibly can. And so it's like, you're just, you normally breathe out and then be like, I'm trying to get all the air out. And I'm like, you're forcing all the air out. And you can force out about another liter, 1,200 milliliters of air. Again, I wouldn't ask you a number. That's your expiratory. So what you can forcefully breathe in, what you can forcefully breathe out, inspiration, expiration. What do you think residual volume is? Can you force out all the air out of your lungs? No, your lungs would collapse. You always have residual volume. Even if you tried, you think you're like, there's no more air left in the lung, I forced it all out. There's still air in your lungs because they didn't collapse. You still have about 1,200 milliliters or about 1.2 liters of air still in your lungs. So that's your residual. It's always there. Now, then there's capacities. When we want to evaluate, and I'm like, different disorders, capacities are adding some of these together. So we call an inspiratory capacity. This is anything that's going in, but it's adding 2 volumes together. It's what you normally breathe in, your normal breath, so it's your normal tidal volume, and what you can force in when you try to take a deep breath. So it's just adding what you normally breathe in at rest, plus what you can force in. So it's like, that's your capacity, it's just adding 2 volumes together. The functional residual capacity is after you've breathed out. You're just sitting there right now and you breathed out. After you've breathed out, this is your functional residual capacity. You've breathed out air, but you still have air in your lungs. Some you can force out, some you can't. They call this the functional. It's still functional air in your lungs after you've normally breathed out. The bottom of your tidal volume, it's, you've already breathed out. You still have this functional air in your lungs. Vital capacity is the volume of your normal breath, everything you can forcefully breathe in, everything you can forcefully breathe out. I'm like, this is the air I like to think. This is the air you can control. How much can you breathe in, your normal resting breath, and then how much you can force out. And I'm like, and you have approximately, and again, that can depend on males versus females, size of bodies, things like that. You can, on average, you breathe into the biggest possible breath that you possibly can, and you blew all of it out that you possibly could. It's about 4,800. Now, the only thing we add in for our total lung capacity is the fact that no matter what you do, you're always going to have this residual volume. So total lung capacity is everything you can control of your air, breathing in, breathing out, and the air that still is going to be left in there, because you can't force it all out. Now, if you're like, I don't like pictures that look like that, there's a table too. There you go, in case you want to look at it. In your book, it's on page 822. And I'm like, it again is just explaining what each volume is, what each capacity it is, and it tells all the abbreviations, which to me looks more confusing, but it's like total lung capacity is your tidal volume, rise and fall like the tidal, your inspiratory reserve, your expiratory reserve, and your residual, all of them. Sometimes they get a little confusing when they just have all of those abbreviations everywhere. Now, we also have air, and I'm like, in our lungs, we consider it, and I'm like, our spaces in our lungs, where we find some air, I'm like, it's called anatomical dead space. And I'm like, which means there's air in our lungs that really are not doing anything for gas exchange. So that means they're not in the alveoli, was where we're going to have gas exchange taking place. But we still have air in some of our passageways. I'm like, so we still have air hanging out in the bronchi, so they're not in the lungs, but they're in part of the respiratory system, whether in the bronchi or the trachea, they're not in the lungs. But we still have approximately 150 milliliters of air that hangs out in these big passageways. And I'm like, that's not doing anything. You know, we're really not controlling breathing in, breathing out. It has nothing to do with the lungs, but there's still some air there. There's also some dead space that can happen in your alveoli itself. It's called alveolar dead space. It's non-functional alveoli. So something happened to these alveoli where gas exchange should be taking place. And I'm like, there may be an obstruction, which means air can no longer get in and out of it. It's not doing anything. You can't get oxygen in. You can't get carbon dioxide out. Or there was some type of collapse of that alveoli. It's not going to help you in breathing. Now, your total dead space is just adding these two up. You know, what air is hanging out in passageways, such as your trachea, it's not doing anything. It's just hanging out. You know, it will go in and out, but it's not doing anything for gas exchange. And the alveolar dead space, all those alveoli that aren't doing anything because they're damaged. And I'm like, so we've got some dead space in our respiratory system. Usually not that much. Now, when we want to determine all of these volumes and all of these capacities, we use an instrument called a spirometer. It just measures the volume. If you've ever used one, and I'm like, or if you've had patients that use them, and I'm like, literally, they put it in your mouth, and you're like, take a deep breath, and then blow it all out. And they can sit there and measure some of those volumes. Now, what these, you know, looking at volume differences, which then looks at capacity differences, things that you can start to notice if you're having respiratory problems. One, we can look to see if there's an obstructive pulmonary disease versus a restrictive disorder. And obstructive means, yes, there is resistance to airflow. Air does not, like something's preventing air from going in smoothly. And so your total lung capacity, and I'm like, there's going to be compensation. Sometimes air gets stuck in the lungs and it can't get out. Your total lung capacity, I'm like, your residual volume, and your functional, I'm going to say, your functional residual, I forgot the C. And I'm like, capacity, all increase. Now, a restrictive disorder, so, you know, this is some type of resistance. Air is not getting in like it should, or air is not getting out like it should, so it can get trapped in there. And I'm like, restrictive disorders just means you have a reduced total lung capacity due to some type of disease, due to some type of fibrosis, some type of scar tissue, some type of damage. And I'm like, you've got damage to your lungs. You know, even if you tried to breathe in, your total lung capacity is not going to be 6 liters or 6,000 milliliters like it should. And I'm like, there's just some type of restriction to the volume. And so you've got lots of different volumes and lots of different capacities all declining. And I'm like, and they can compare these as they do this. Now, if I remember correctly, how many of you have to take advanced? A bunch of you. You'll do some of this in one of your labs where you get the spirometers and start looking at, you know, determining the volumes and the capacities. Now, we also want to know, you know, other than what are these volumes, you know, how much air is actually going in and out per minute. We call it minute ventilation. So it's the total amount of gas or air that flows in and out of our respiratory tract in 1 minute. So it's 1 minute. Now again, that's at rest. At rest, you're breathing in and breathing out about 6 liters of air every minute. Now, if you start exercising, you're taking deeper breaths and way more frequent breaths. That can easily increase all the way up to 200 liters per minute. However, just looking at that, it's only a rough estimate, of how good your respiratory system is. And I'm like, and that also comes into play with your cardiovascular system. How good are we at matching breathing and oxygen carrying capacity with your blood? Now, a good indicator of effective ventilation is looking at your alveolar ventilation rate. So it's not just how much air is going in and how much air is going out. And I'm like, but we want to, out of the lungs, we want to know, how much of the gases, how much gas is going in and out of the alveoli, not just all of the different chambers, and all of your passageways during any particular amount of time. Now, to calculate this, one of the biggest things we have to include is we have to get rid of our dead space, because we don't care about any of the air that's in the passageways, and we don't care about any of the air in damaged alveoli, because nothing is going to be going in and out where you're going to have gas exchange taking place. So to calculate our alveolar ventilation, so we're going to have gas exchange taking place, we have to calculate our frequency. How many breaths per minute do we take? And then we have to calculate the volume that we're breathing in. So we have to take our total volume and just subtract any of the dead space. Dead space is normally constant. Like your damaged alveoli usually stay damaged. The size of your bronchial tubes and your trachea stay the same. And I'm like, we just take that out of the equation. And we just look how many breaths times the volume of each of those breaths. And that's looking at how much actual air is getting to your alveoli. That's bringing on oxygen and getting rid of carbon dioxide. Now, rapid shallow breathing, if you're like hyperventilating, actually decreases your alveolar ventilation rate. And so I'm like, if you started hyperventilating, and I'm like, which means you have less air getting in and out of your alveoli, any guess what will happen? You'll pass out. And I'm like, it just means you're not going to get enough oxygen that you should. I'm like, you decrease that ventilation rate. You're not getting enough oxygen into your lungs. So I'm like, hyperventilating can make you pass out. And then you calm down from whatever you're hyperventilating while you're passed out. Now, there's also some non-respiratory air movements. These are just things that, can move air around in our respiratory system. Most of them are reflex examples. If you cough, you're forcing out air. If you sneeze, forcing out air. Crying can change your ventilation rates. Laughing, hiccuping, yawning, all of these things are just non-respiratory air movements. It's air going in or air going out. It's really not for gas exchange purposes. It's just other things that are moving air in and out. Now, gas exchange. I'm like, so gas exchange between blood, lungs, and tissues. We have to have gas exchange in our lungs. We breathe in air, and what gas do we want in? Oxygen, and then we breathe out, and what gas do we want to get rid of? Carbon dioxide. We have gas exchange happening in our lungs. We also have gas exchange happening in all of our tissues, because our tissues need what gas? Oxygen, and what the tissues make what gas that they need to get rid of? The other gas, the carbon dioxide. Now, we have two types of respirations, meaning we have two types of gas exchange. External respiration is the diffusion, the switching of the gases in the lungs. The fact that you breathe in, oxygen in, carbon dioxide out when you breathe out. Like that's a gas exchange taking place in the lung. We call it external respiration because it's like the outside air that you are, bringing in. External. Internal respiration is the diffusion of these gases into the tissues. So what's happening in your muscles and everywhere else in your body? So nothing lungs. It's once that oxygen is in the body at the lungs, now we can drop it off everywhere else in the body. So external, because it relates to the lungs, breathing air in from the outside. Internal is everywhere else in the body. Now, both involve gas laws. Ready for more laws today? And I'm like, and they both involve of what's actually in the gas that you are breathing in. And I'm like, what's in your alveolar gas? So, our first law, know the laws. Got that? The first law is called Dalton's Law of partial pressures. And I'm going to do math just to explain it. I calculated all my math already. It's the total pressure exerted by a mix of gases, or the sum of, I'm like, which is the sum of the pressures exerted by each gas. And people are like, I don't get that. Don't blame you. What are you breathing in right now? Oxygen. Is that it? Nope. What else are you breathing in? There's one that there's more of than oxygen. God, I was always told I was breathing in oxygen. There's another gas you're breathing in way more of. Way more. Like 4 times more. Anyone? Nitrogen. And I'm like, you're like, oh yeah. I'm like, and I'm like, these are the top 2 gases you're breathing in. Yes, there's some carbon dioxide, but it's actually pretty, not very much. And I'm like, and so when we're talking about, a sum of pressures of each gas, we are breathing in more than one type of gas right now. Now, do you remember what atmospheric pressure is? It's a number I'm looking for. 760. Now, our Dalton pressure, the total pressure, our total atmospheric pressure around us is the sum of all of the individual pressures. And I'm like, of the gases that you're actually breathing in. Now, nitrogen, and I'm like, makes up, is it 79% of the air? 79% of the air, which leaves oxygen. And I'm like, I'm going to round to the wholest number, and we're just going to say it's these 2 gases. Make up then 21% of the gas that we're breathing in. Yay. Yeah, there's some, like, if I didn't round. And I'm like, some point, blah, 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 whatever, of other gases. Now, if I do math, 760 times 0.79, 79%, when you multiplying it, 0.79, the total amount of pressure that nitrogen contributes to the 760, 597. Now, I'm not going to ask you to do math and ask you to know these specific numbers. I just want you to understand, like, what does this mean, the sum of pressures exerted by each gas? Now, 21%, or if I do the math, 0.21 times our total, 760. I don't need that one. 159. Add them together. It's not 760, but it's close, because I rounded. $756. Now, yes, and you're like, but that's not 760. You're right. The other 4 does come from, there's carbon dioxide gases, there's sulfuric gas, there's methane gas, there's these other ones that contribute a little bit too. But Dalton's law of pressure is just saying that, yes, the total pressure is exerted by a mixture of gases. Now, partial pressure is just saying, what is the pressure of each gas? Nitrogen, partial pressure is 597. Oxygen's partial pressure, 159. And I'm like, and it's proportional to its percentage, how much oxygen is there, how much nitrogen in there. So Dalton's law is just talking about, what are we actually breathing in? And I'm like, there are multiple gases that contribute to what you are breathing in. Henry's law, another law. And I'm like, Henry's law has to do with gas that is mixed in the liquid. Because I'm like, yes, you have gas in your body. However, do you have bubbles of gas all over in your body? Now it's all dissolved in things. Now, each gas, whether it's oxygen, nitrogen, or carbon dioxide, will all dissolve in liquids like plasma. So we've got oxygen and carbon dioxide getting transported in our blood. Plasma is one place we can find both of these. Like each gas is dissolved in proportion to its partial pressure. Now, so like if we've got more, more oxygen, a higher pressure of oxygen, more can get dissolved in fluid. My little note, because I know I didn't write down carbon dioxide, it's in there. My little note, and I'm like, even though there is more oxygen that you are breathing in from the environment, carbon dioxide is more soluble in water than oxygen is. Now, and people are like, really? Yes. And I'm like, carbon dioxide is more soluble in water than oxygen. So when you crack open your can of soda, what's in there? Carbon dioxide. And I'm like, the carbon dioxide likes the liquids. It likes the water. It's 20 times more soluble in water. It would be really hard to get oxygen in the water. And then as soon as you cracked open that can, all the oxygen would want to come out because it would not want to stay in the oxygen or in the water. Now, the interesting part, little nitrogen gas dissolves in our water. So even though we are breathing in 79% of nitrogen right now, it really doesn't do anything because it doesn't like to go into solution. So that's fine. Now, how temperature can affect the solubility? As temperature rises, solubility decreases. These gases do not like to stay in the liquids when the temperature rises. Now, and you're like, okay, I still don't get it. Think of this outside of AMP, and I'm like, you've got a can of soda, and you know it's carbonated, it just came from the refrigerator, great. A cold can of soda, and I'm like, cold, and I'm like, will retain its carbonation longer than a warm can of soda. As it sits out, it's 100 degrees out that day, and your can of soda is sitting there because you forgot about it, and I'm like, as the temperature of that can rises, the carbon dioxide leaves faster. The warmer it is, the faster that carbon dioxide leaves, because as temperature rises, the solubility decreases. It comes out of solution. So if you want carbonated beverages, keep them as cold as possible. Now, this happens as well in our body, that yes, as the temperature rises, these gases come out of fluids. Sometimes that's good if we want oxygen going. I think we'll get to the part of the lab, or my lecture, I'm like, we want oxygen going where it's getting warmer, because you're usually working out. Now, looking at what's actually in the gas in your alveoli. The only two things, I'm like, that I want to look at, or compare, I'm like, this is air that's in your alveoli. You breathed it in, and you're like, well, shouldn't that be the exact same air that's outside? Nope. I'm like, there's some slight differences, mostly because of the carbon dioxide that's there and how much water is there. As you breathed in, you humidified the air. And so that the air that is in the alveoli, by the time it got there, has more liquid to it. And so this is comparing, this is, air that's in the atmosphere all around us. This is air that's in your alveoli. My bottom one that I have in the red square, 0.46. Water concentration in your alveoli, 6.2. We've humidified the air. Also, what happens in the amount of carbon dioxide is also higher in our alveoli than in the air around us. 0.04 carbon dioxide. This is why I didn't care. 0.04. Little small, so that's why I, didn't care about mixing it in there. 0.04, and I'm like, percent of the air around us is carbon dioxide. Alveoli, 5.2. Mostly because there's constant unloading of carbon dioxide into the alveoli. So even though you breathed air in, there is still carbon dioxide that is nonstop getting unloaded into the alveoli. So there's a little bit of differences. So yes, we have mixing of gases with every breath. Now your external respiration. So this is, we're talking about air going in. This is the breathing. This is the diffusion of gases that are happening at the lungs. Everything that happens in tissue is like the reverse. So this is looking at the exchange of oxygen and carbon dioxide at the respiratory membrane. So in your lungs, how are we getting oxygen in, getting carbon dioxide out? Now, there are three things that influence our external respiration. So this gas exchange happening at our lungs. The first one is how thick is our respiratory membrane, how much surface area is there for gas exchange to take place. And then we have to look at what are some of the pressures of oxygen and carbon dioxide, and the gas solubilities. Again, carbon dioxide is more soluble than oxygen is. And then our ventilation perfusion coupling, which it sounds more complicated than it is. Now, the first thing that influences this external respiration is that thickness and surface area of the respiratory membrane. Our respiratory membrane has to be really thin. And so size-wise, we're in the micrometers, micrometers, and I'm like, we're in the micrometers. And I'm like, really, really thin. I know it says 0.5 to 1 micrometers thick, but I'm talking, that means it's really thin. You want oxygen and carbon dioxide to easily be able to get across it. And I'm like, so it should easily be able to flow. So it has to be really thin. Also, our respiratory membrane should have a really large surface area. The more surface area, the more gas you can get across it as well. The problem becomes if they start to get waterlogged or you start to have fluid in your lungs, which can happen with people that have pneumonia. We no longer have, and I'm like, a large surface area because it's covered with fluid, and I'm like, occasionally that leads to a thickening of your respiratory membrane, and you don't get enough oxygen in and enough carbon dioxide out. And so I'm like, we need it really thin. Also, what can happen are things that can reduce the surface area. For people that have emphysema, which at the very end of this PowerPoint that I know we won't get to today, it talks about disorders. Emphysema is one. Emphysema breaks down the walls of adjacent alveoli. So here's your grapes. Yay. Lots of surface area. On every line I just drew, that's all surface area where you can have gas exchange taking place. What happens with alveoli, it breaks down walls. And so all of a sudden, instead of having like 4 individual alveoli all kind of connected together, they've morphed into this really big one. When I erased the lines, I erased the surface area, which means you can't get enough oxygen or enough carbon dioxide out. Also things that can reduce surface area, tumors in your lungs, any type of inflammation or any type of mucus buildup in your lungs. Now, the other thing that helps or affects your external respiration are the pressure gradients and your gas solubilities. It has to do with diffusion. Things want to go from high to low. It's the exact same thing with pressure. Air is under pressure, doesn't like it, and wants to go where there's less pressure. Now, this is looking at, I was going to try to draw today. I brought blue and I think red. Yes. I don't know what I'm going to draw yet. And I'm like, if we have venous blood versus alveolar, versus the alveoli, and I'm like, we're going to look at how much oxygen is in veins. Is there a lot of oxygen in a vein? Not talking about the pulmonary. Is there a lot of oxygen in your veins? No, those should be veins that are bringing unoxygenated blood back to the lungs. So if I have, here's my blood supply. Isn't it beautiful? And I have an alveoli. It's beautiful. I should label it in case you don't get it. If I have very little oxygen, the pressure of oxygen in my vein, that's your partial pressure of oxygen, is about 40 millimeters of mercury. But in my alveoli, you just breathed in, and what are you breathing in? Oxygen. Oh, you don't care about the nitrogen. And I'm like, but you just got done breathing in oxygen. So the partial pressure of oxygen in this alveoli is about 104. Pressure difference. Where does oxygen want to go? 40 to 104 or 104 to 40? It wants to go from high to low. So the fact that there is a difference in the pressures in your veins, because there's not a lot of oxygen there because they dropped it all off, versus what you just breathed in, which has a lot of oxygen, the oxygen naturally wants to go from one area where there's lots of oxygen So where there's little oxygen, it's a pressure difference. And so this difference drives the oxygen flow into the blood. Now, they hit equilibrium in 0.25 seconds-ish. And I'm like, so it does not take very long for the oxygen that's here. It's like, I don't like it here, lots of pressure. And I'm like, and it all goes into the veins and the blood supply that's right there. Now, the reverse. There's oxygen. I feel like I need another color than my blue. Is if we look at carbon dioxide. Now, well, we've got carbon dioxide in our veins. My purple is my carbon dioxide. Partial pressure of carbon dioxide in our veins is approximately 45 millimeters of mercury. In our alveoli, the partial pressure of carbon dioxide is approximately 40 millimeters of mercury. Is there a big difference? No. And so this is where it says the gradient's not as steep. There's not as big of a difference in numbers. Doesn't matter. And I'm like, doesn't matter. And I'm like, where is the carbon dioxide going to flow? I have 45 and 40. It wants to go to what number? It wants to go to the 40. Carbon dioxide that's in your veins is going to want to go into the alveoli. Even though it's not as big of a difference, it does not matter. It has to do with the fact it's more soluble in fluids, which means it can also come out of the fluids just that much faster as well when it gets to the alveoli. Now, carbon dioxide gets dumped in the alveoli. Where is it going to go? It's in the lung. It will get breathed out. And so, yes, as you're breathing in, you upped your oxygen level. That oxygen goes into your veins. And I'm like, same thing. And I'm like, your veins are constantly dumping carbon dioxide off into your alveoli, which then every time you breathe out, you're breathing out. I'm like, so they're moving just based on their concentration differences. Now, I was going to say, I'm like, if we did this, and I'm like, off to the rest of our body, these numbers just get flipped around. And I'm like, because then oxygen and carbon dioxide, they switch. And I'm like, I want oxygen going into tissues. And I'm like, and carbon dioxide going into veins. Now, the last thing that affects this external respiration, so surface area, we've got our, the surface area, the thickness of the respiratory membrane, and our pressure differences is called perfusion, the ventilation perfusion coupling. Sounds horrible. I'm like, it's a horrible word. All we're looking at is how much blood are we bringing to the, how much blood are we bringing to the lungs compared to how much gas is there. We'd like to try to match them up to try to be as efficient as possible. I'm like, we just want to match how much air goes in for how much blood is there. I'm like, so it depends, if we've got lots of carbon dioxide you have to unload because you're working out, you probably want to bring more blood there. And I'm like, if you need more oxygen because you're working out, you probably need more air going in. And so we try to match them to be as efficient as possible, getting just enough blood there, getting just enough air there so we can have that gas exchange taking place. So this is just showing, I'm like, what we can do. We can dilate and constrict blood vessels, and then we can change the diameter of bronchioles to get more air in or to constrict more air. So changes in your partial pressures of oxygen. I'm like, if you have lots and lots of oxygen in your alveoli, whether you're breathing in a straight oxygen mask or you just had lots of deep breaths of lots and lots of oxygen, you have lots of oxygen in your alveoli. We're going to try to dilate our arterioles to be able to pick up. We get more blood supply there, and they can pick up all of that oxygen. If you've got lots of oxygen here, we want lots of blood supply there to pick all the oxygen up. Reversed, if your alveolar oxygen is low, so there's not a lot of oxygen, we're going to slow down the blood supply there. So then when the blood does get there, it's there long enough. It's going slow, but it's there long enough to pick up the oxygen that is there. So we try to match, how much blood we bring. Now, carbon dioxide changes the bronchioles. if you have lots and lots of carbon dioxide in your alveoli, like there is just, you know, a ton of carbon dioxide in your alveoli, your bronchioles will dilate. They will get bigger. Now, like, here's your trachea. Your bronchioles will get bigger. If they get larger, that carbon dioxide can leave a lot faster. We want to get rid of it. If you don't have a lot of carbon dioxide, we don't need to waste the energy in having really big, like bronchi. And so I'm like, if we have less carbon dioxide, your bronchioles are going to be smaller, they're going to constrict, and we'll just slowly eventually get rid of the carbon dioxide as it builds up. It allows us to get rid of carbon dioxide when it builds up. We don't like excessive carbon dioxide in our body. So we just are matching oxygen and gases versus blood supply. That's your basic ventilation perfusion coupling. Matching blood supply to the amount of gases. Not super bad. Now, internal respiration. This is gas exchange at your tissues. So it's like the reverse of all of this. Now, so you're still looking at partial pressure differences. You're still looking at diffusion gradients. Yes, when I'm like, they still want to go down their gradients. So your tissue oxygen is always lower, I'm like, than in your arterial blood. I'm like, I don't know if I want to reverse this. We'll just say that I need another color. Here's your tissue over here. So there's your lungs. Here's your tissue. There's still my blood vessel, but here's your tissue. Isn't it beautiful? Tissue, whatever it is. Or we can make it hyaline cartilage. Now, your tissue oxygen is always lower than whatever is in your actual blood vessels. And so just because the number is here is 40, generally if I'm bringing oxygenated blood here, it's not going to be that low. But just for playing with numbers, and I'm like, the partial pressure of oxygen in this tissue, maybe 20. Oxygen's going to want to go into your tissues. It's still going to want to go from a high to low. And the same thing, and I'm like, tissues generate a lot of carbon dioxide. And so you're going to have a lot of carbon dioxide in here. If this was 45, and I'm like, this number might be 60. Carbon dioxide will get dumped into your blood vessels. So our tissues pick up oxygen and get rid of carbon dioxide. Now, since we're talking about always the fact that our tissues generate oxygen, hopefully this looks kind of familiar. Glucose plus oxygen gives us, I don't want water up there yet, generates carbon dioxide and water. And I'm like, cellular respiration. We need to eat sugar, we need to breathe oxygen, it generates carbon dioxide and water. And I'm like, so we're always generating carbon dioxide in our tissues, but we always need a constant supply of oxygen. Now, transporting the oxygen and the carbon dioxide. Oxygen transport is easier. I want to get to the carbon dioxide. I think I'll do it. And I'm like, one, a little bit of oxygen is dissolved in plasma. Oxygen doesn't like to be dissolved all that much in liquids. So there's not a lot in plasma, because plasma is mostly water. Most of our oxygen is bound to hemoglobin. So this is why I'm like, it all comes back when we talk about hemoglobin, and it's attached to the iron. And I was going to say, every single hemoglobin can attach to 4 oxygens. There's like 4 heme groups, so every hemoglobin can hold 4 oxygens. So that's what most of our oxygen, how it gets transported around in our red blood cells on hemoglobins. Now, if there's a lot of oxygen on your hemoglobin, we call it oxyhemoglobin. It's like we squish the 2 words together. It's just oxygenated hemoglobin. Now, if that hemoglobin that's holding lots of oxygen, because it can hold 4, if it has dropped oxygen off, it has lost some of its oxygen, it doesn't have 4 anymore, we call it reduced hemoglobin, because there's not as many. It also has the nickname of deoxyhemoglobin, which just means we removed some oxygen from the hemoglobin. Yay. So in the lungs, and I'm like, HHB is our reduced hemoglobin, or our deoxyhemoglobin. I don't know why they have the extra H in there. And I'm like, to me, I call it R, reduced hemoglobin. And then you breathe in. Doesn't have a lot of oxygen. Oxygen in our lungs. And now we have oxygenated hemoglobin, or oxyhemoglobin. And I'm like, plus hydrogen ions. In our tissues, it does the reverse. We take oxygenated hemoglobin. We drop off the oxygen, and we have reduced. And then it goes back to our lungs, and so on. Now, the loading and unloading of the oxygen is facilitated by the shape of hemoglobin. And I'm like, as oxygen binds to hemoglobin, more oxygen wants to bind. It's like a positive, some of our positive, not reinforcements. But I'm like, it's one of those, it will change the shape. As one oxygen binds to hemoglobin, it can bind 4. The hemoglobin's like kind of changes its shape, like, oh, I like oxygen. Let me change my shape and try to grab onto 3 more. And then the reverse, as one oxygen leaves, the hemoglobin's like, oh, apparently we're releasing these now, and they change their shape, and the other 3 will naturally want to leave. And so I'm like, it changes shape, so it can easily pick up oxygen, but can easily get rid of oxygen. We call it fully saturated if it has all 4. Partially saturated, it has less than 4. Now, the rate of picking up oxygen, decreasing oxygen, changes based on the partial pressures of oxygen, depends on how much oxygen is there. It can depend on temperature because of some of the solubility. Your blood pH, what's the partial pressure of carbon dioxide? These can all change how much oxygen gets picked up and released. Now, in your arterial blood, so in your arteries, the partial pressure of oxygen in your arteries is approximately 100 millimeters of mercury. It can take 20% milliliters of oxygen for every 100 milliliters of blood. So it's about 20% of your blood is oxygen, guess-wise. And I'm like, and your hemoglobin is usually 98% saturated in your arteries. So it's not always fully saturated, but hemoglobin's mostly saturated in your arteries. You just picked up a lot of oxygen. So if you're 98% saturated in hemoglobin, even if you increased the partial pressure of oxygen, if you start to breathe more deeper to bring in oxygen, it's really not going to change a lot. 98%, or maybe at 98.5. So even if you breathe deep, usually in your arteries, they're going to max out their oxygen. Breathing deep is not going to change a lot for how much oxygen binds. In your venous blood, so the blood in your veins, you have a lot less oxygen because it just got done dropping it all off. So your oxygen level is about 40. There's only about 15% volume of oxygen, and your hemoglobin is still 75% saturated. And so even though veins, we say that they're unoxygenated, are veins unoxygenated? No, they're not at all. And I'm like, even though your blood vessel dropping off oxygen everywhere in our body that it needs, they're not unoxygenated. Our veins still have lots and lots of oxygen, 50% volume oxygen, and 75% of our hemoglobin is still, full of oxygen. And so we call this oxygen that's still in our veins, it's our venous reserve. It's like our reserve of oxygen. I'm like, so you still have oxygen there. This is just showing the little difference because our normal arterial blood is saturated, usually at about 98% for hemoglobin. Changing pressures of oxygen, if you travel high, if you travel low, changing your partial pressure of oxygen is not going to change a lot. I'm going to say one of my things, I'm like, at sea level, your hemoglobin is 98% saturated. If you go to a higher altitude where there's less oxygen, your hemoglobin is still about 95% saturated. Now, even though it's not as saturated, and I'm like, and that's not a big difference, do you feel the difference if you ever go to a high altitude? You still can feel the difference. And I'm like, yes, but that doesn't mean you're generally going to fall over and just die because you went to a higher altitude. And I'm like, unless you're out running, then you feel like you're going to die, but you don't. Other factors that influence how much hemoglobin picks up, how much of the hemoglobin picks up oxygen, the temperature, hydrogen ions, which affect pH, how much carbon dioxide. All of these can change the structure of hemoglobin a little bit. Anytime you change the structure of hemoglobin, you change how much it likes oxygen. Usually these things all make it decrease the affinity for oxygen. And so hemoglobin doesn't like the oxygen and allows it to unload from the blood and get into various tissues. Anything, and the opposite, anything decreasing in these factors, you know, I'm like, decreases how much unloading. We don't want to get rid of our oxygen. I want to get to carbon dioxide. Well, I'm going to kind of, because I wrote this up here for a reason. As cells metabolize glucose and use oxygen, they are making carbon dioxide. Because you're making carbon dioxide, that's increasing. We are also increasing our hydrogen ions. And you're like, well, where's that? Part of the water. Water will split up and release a hydrogen ion. And so when our cells taking in sugar, breathing in oxygen, they are releasing carbon dioxide and hydrogen ions. Now, the fact that, and I'm like, we have more carbon dioxide and we are increasing hydrogen ions. Hydrogen ions are acidic. So here's my, conundrum. If you increase acidity, what does that do to the pH? It decreases the pH, because anything really low on the pH scale, like the lower you go on the pH scale, the more acidic it is. So declining blood pH, I'm declining my pH. I'm meaning I'm getting more acidic, because that opposite thing confuses people. You're more acidic, your pH is lower. And I'm like, and as that pH gets lower, it's more acidic because you made it more acidic. I'm like, what it will do? And I'm like, and the fact you have more carbon dioxide. It's called the Bohr effect. Your hemoglobin oxygen bond weakens and you start dropping off oxygen. If you're using oxygen, that's probably where you want to drop oxygen off. And so as certain cells, if I'm working out one muscle, whatever it is, I'm at the gym working out certain muscles, as those muscles are, taking in lots of oxygen, releasing lots of carbon dioxide, and lowering the pH, right there, it's called the Bohr effect. Hemoglobin molecules that are attached to oxygen, like, ooh, there's a little more acidic right here, and there's a lot of carbon dioxide in these muscles. Let's drop off the oxygen there. It's called the Bohr effect. And I'm like, so oxygen gets unloaded where it's needed the most. Other things that help it, heat production also drops off oxygen. Because usually when you're working out certain muscles, it generates heat. That's why you get sweaty when you work out. And I'm like, as it increases in temperature, also drops off oxygen. All right, here's what I want to get to. Carbon dioxide, 3 different places where we can transport carbon dioxide. A little bit in plasma, more than oxygen. Some is bound to the globin protein of hemoglobin. We call it carboaminoglobin. But what I care about, highlight it, 70% is transported as bicarbonate ions, and HCO3 is a bicarbonate ion. Anything ion has a charge, include the negative, in plasma. The majority of carbon dioxide is transported as your bicarbonate ion. Why I care? Why do I care about this bicarbonate ion? Most of it's not attached to that hemoglobin, and it just unloads and doesn't unload. And I'm like, we take carbon dioxide. We don't want carbon dioxide. Most of it is not dissolved in fluids. I'm like, but carbon dioxide plus water. Highlight this little equation. Carbon dioxide plus water makes carbonic acid. Write it up. Now, there's a reason why the arrows are like that, because anything that happens this way can also be reversed. And carbonic acid can break apart and become hydrogen ions and HCO3. There's your bicarbonate ion. Bicarbonate. Really sloppily. Now, yes, this making of carbonic acid, and then eventually, so carbon dioxide gets transported around in our body as a bicarbonate ion. So most of the carbon dioxide that our body generates, it's not CO2. It immediately gets changed to this bicarbonate ion. This happens in our red blood cells, there's an enzyme, enzynase, and there's an enzyme called carbonic anhydrase that takes the carbon dioxide, turns it into carbonic acid, part of its name, carbonic, and I'm like, and then it gets broken down, and I'm like, to hydrogen ions and bicarbonate. It can reverse and go the exact same direction, the opposite way though. Now, in our systemic capillaries, this bicarbonate ion will easily go from red blood cells into plasma to get transported into our lungs. So in capillaries, and I'm like, this can easily go right back and get transported to our lungs. In pulmonary capillaries, this bicarbonate ion moves into red blood cells. Now, if I drew a red blood cell, if I have bicarbonate ion, it has a negative symbol. It goes into red blood cell. There's the divot. This doesn't like to be negative. So something negative has to leave. Chloride will leave. And I'm like, so bicarbonate ions can move into red blood cells. Chloride ions will leave. And as they go in to the red blood cells, they bind with hydrogen ions, and they form carbonic acid because of the enzyme that's there. And yes, once they go in there, that carbonic acid gets broken down into CO2 gas and water, forgot the O, and CO2 goes into the alveoli. So, and I'm like, bicarbonate ions will go into the red blood cells. They make their way to the lungs. And I erased my diagram before, but you've got a red blood cell with lots of carbonic acid in it. It goes to the lung. This red blood cell releases carbon dioxide into the alveoli. And where does the carbon dioxide go once it's in the alveoli? It will go out and you breathe it out. But carbon dioxide itself, CO2, didn't go to the lungs right away. It was transported around. Bicarbonate ion went into our blood cell, and that, yes, it's like HCO3, this bicarbonate ion, it's really CO2. It eventually has to become carbonic acid and then get released for you to be able to breathe it out. Trying to think, I'm like, what else do I want to make sure you get before we leave? I don't know if I want the Haldane effect right now. Fine, and I'm like, the Haldane effect, the amount of carbon dioxide transported is affected by how much oxygen is in the blood. If there's not a lot of oxygen in your blood, and I'm like, it's going to pick up carbon dioxide, and I'm like, to try to get rid of it. It just means we want to encourage carbon dioxide exchange in tissues and lungs. So when it drops off oxygen, so there's not a lot of oxygen, it will pick up carbon dioxide. So if this is dropping off carbon dioxide, hopefully it then picks up oxygen. That's the basics of your Haldane effect. As it drops off carbon dioxide, it picks up oxygen. I'll end right there. I'll talk about the buffering, I'll record it though. My little note, and I'm like, because I will record the rest of it. As I talk about that, have this available if you're listening to me, because I can't like point at stuff. So I might try to do something where I can be like, and remember, as it goes this. I'm like, so have that little formula.